Okay, this is a short chalk talk on RTAs. I couldn't find a good YouTube video that is the highlights for internal medicine residents for future hospitalists, so I'm making my own about RTAs. Unfortunately, the microphone sounds like I'm underwater, but just bear with it. Anyways, the diagnosis is in the name. It's an acidosis. As most people know, renal RTAs cause non-anion gap metabolic acidoses. And later on, we'll get to how to diagnose these, how to differentiate the different RTAs. But first, let's just start off showing what part of the kidney the RTA is affecting. So let me draw a glomerulus, the loop of Henle, the distal tubule, and the collecting duct. And let's just start off with type 1 RTA. Very simple right here. Type 1 RTA is also called the distal RTA. Distal RTA makes sense. It's the distal tubules that is affected. Type 1 RTA, the numbering does not make sense. It's actually, the numbering is when it was discovered. This is the first RTA discovered. That's why it's type 1 RTA. But for the RTAs, remember that the numbering doesn't make any sense. Distal RTA makes a lot of sense. And in this, the main lesion is at the distal tubule, and the kidney is not able to excrete hydrogen into the urine. So that's not working. What does that mean? That means there'll be less hydrogen in the urine. So the urine pH will be greater than 5.5. Other things to know, because it's the distal RTA, there's not much kidney left. And so the kidney can't compensate this lesion, which means you'll have a worse acidemia or acidosis. Oftentimes you can see the bicarb, the serum bicarb, less than 12, worse acidosis. Other things to know about the distal RTA, you're going to have a low serum potassium, and you're not going to see the RTAs very often. They're rare. You kind of have to go looking for them, and that's why you'll see them more on the boards than in the wards in the hospital. But the rare diagnoses that can cause distal RTAs, type 1 RTAs, you got Sjogren disease, you got rheumatoid arthritis, you have the one drug that probably will come up often on the boards is amphotericin. So amphotericin can cause this distal RTA. That's at least we're getting to know what the distal RTA, type 1 RTA is. Now let's talk about the type 2 RTA, also called the proximal RTA. Type 2 RTA. The main lesion in this one is that the proximal tubules are unable to reabsorb bicarb. So, unable to reabsorb bicarb. This process is not working. Things to know about this, it's early on in the tubule system, and so the kidney can compensate. The urine pH will be less than 5.5. Because the kidneys can compensate, the acidosis will be more mild. Often you'll see a serum bicarb between 12 and 20, indicating it's more mild. Also in type 2 RTA, proximal RTA, the serum potassium will be low. And like I said, you're not going to see this very often in the hospital or in the wards. But the classic, board conditions that are associated with this are acetazolamide. Because acetazolamide is a drug that blocks bicarb reabsorption. That makes sense. Another one could be topiramate. And then there's a classic, more often diagnosis that is associated with type 2 RTA, multiple myeloma. Sometimes you'll hear an old attendee who said, "Oh, I saw a non-anion gap metabolic acidosis, couldn't figure it out, so I did an SPEP or UPIP." diagnose multiple myeloma. It's probably fake news. They might just be stealing it from a podcast. That's type 1. That's type 2. The last one we should go over is the type 4 RTA, also that affects the collecting duct, also called hyperaldosteronism RTA. That is a hard word to spell. Hypoaldosteronism RTA. That is a hard word to spell. Or aldosterone resistance. These are just things you have to memorize in order to understand the RTAs. There's no good way to kind of figure out unless you're some PhD nephrologist or a nephrology fellow attendee. In hyperaldosteronism RTA, the main thing that is causing the kidney to fail in the collecting duct is serum hyperkalemia. In this case, the serum hyperkalemia, it interferes. It causes a lack of ammonia, which causes a lack of ammonia genesis, which causes a lack of ammonium in the urine. So you got to think about things that cause hyperkalemia, and it's easy stuff to remember, right? So it's medications like ACE inhibitors, ARBs, things like spironolactone, spelled something like that. And you also can see type 4 RTAs. Probably the most commonly seen is in long-standing diabetes, which causes a hyporenin and a hypoaldo state. But think about it, that these acidoses from type 4 RTAs, they tend to be mild. And so these mild type 4 RTAs are often managed to control the patient's hyperkalemia, because obviously the potassium is very important. So usually the type 4 RTA is mild. So when we treat the hyperkalemia and when the hyperkalemia is corrected, the metabolic acidosis tends to be corrected as well. So that's the 3 main RTAs. Now let's get into how to diagnose these things. RTAs, non-anion gap metabolic acidoses, also called non-anion gap metabolic acidoses, are also called hyperchloremic metabolic acidoses. So let's go over our rules for acid base. Rule number 1, calculate the pH, get that VBG, ABG, pH will be down, it's an acidosis. Rule number 2, get the PCO2. In metabolic acidoses, the pH and the PCO2 will move the same way. So the PCO2 will be decreased. It's not a primary respiratory. And you'll also see the bicarb is decreased, indicating it's metabolic. For me, rules in the acid-base rules number 3 is calculate the anion gap. And in RTAs, it'll be a non-anion gap metabolic acidosis. You will not have an anion gap. Now, at this point, in the hospital, internal medicine, non-anion gap metabolic acidosis, by far, the most common cause is going to be diarrhea. So check your patient for diarrhea. That's going to make things a lot simpler. If they don't have diarrhea, maybe you start thinking about the RTAs. Or maybe they have diarrhea and an RTA. How are you going to differentiate that? Step number 4 to diagnose an RTA is the urine anion gap. And the urine anion gap, I always have to look it up, but it's the urine sodium plus the urine potassium minus the urine chloride. If this non-anion gap metabolic acidosis is from diarrhea, this urine anion gap is going to be negative. So negative equals diarrhea. And the little catchy way to remember that is gut negative, that's equal to diarrhea. If the urine anion gap is positive, you're thinking about a kidney lesion. So maybe CKD or RTAs. And at that point, if you got a non-anion gap metabolic acidosis, your urine anion gap is positive. How are you going to differentiate between the different RTAs? Number one, you're going to look at the serum K, and as we already talked about, for the type 1, type 2, the K will be low. Type 4, the serum K will be elevated. And number two, you're going to look at the urine pH. That's how you're going to differentiate between type 1 RTA, which will have a high urine pH, and type 2 RTA, which will have a low urine pH. But how am I going to apply this clinically? Clinically, you're not going to see the RTAs. Maybe, you'll see the type 4 RTA because somebody has long-standing diabetes, they're on ACE, they're on ARB, but the acidosis will be so mild it won't matter at all. The way I want you to think about this clinically, if you have a patient who has a non-ion gap metabolic acidosis, you'll see that their bicarb is low. You'll see that the serum chloride is high, serum bicarb is low. And if they don't have diarrhea, then that's when you can start thinking about this renal tubular acidosis. You're not going to see very often. You kind of just have to memorize all this. So it's not a perfect chalk talk, but it's something that can be seen over and over. You can review it over and over and just see the highlights from a hospitalist internal medicine resident about the renal tubular acidosis. Thanks.